Our society is in the midst of a national opioid epidemic that takes more than 130 lives a day. Throughout this video, we will be discussing what we as healthcare providers can do to combat this epidemic and how to develop safer plans for pain control. According to the CDC, nearly 57 million Americans have had at least one opioid prescription filled or refilled in 2017. The average number of opioids prescribed per patient was 3.4, and the average number of days of supply per prescription was 18 days. The CDC also estimates that over 10 million Americans have abused an opioid during their life. Of those, 71% have obtained opioids through illegal channels, and over half, 55%, from a friend or family member who had excess pills from a single provider. In 2022, Piedmont Clinic providers treated over 2 million patients. You can see the tremendous opportunity we have to address this global problem. Our goal is to work together with you to reduce opioid misuse through safer prescribing practices and the use of multimodal pain relief strategies. Thank you for your dedication to making our world safer for our patients and helping us reach our goal of zero harm, making a positive difference in every life we touch.
An important step in improving opioid prescribing practices is the utilization of the Prescription Drug Monitoring Program, or PDMP. The PDMP is a statewide electronic database that tracks all controlled substance prescriptions. Authorized users can access prescription data such as dose and the type of medication dispensed. This type of robust database helps improve patient safety by allowing clinicians to identify patients who are obtaining opioids from multiple providers, calculate the total amount of opioids prescribed per day, and identify patients who are being prescribed other medications that may increase the risk of opioids, such as benzodiazepines. In the state of Georgia, providers are legally required to check the PDMP before writing a new prescription for benzodiazepines or opiates. If these prescriptions are continued, the provider is required to check the PDMP at least every 90 days. There are 4 exceptions to this law. The first is if the prescription is no more than a 3-day supply and no more than 26 pills. Second, if the patient is in a healthcare facility and prescriptions are to be administered on the premises. Third, if the patient has had outpatient surgery at a hospital or ambulatory surgical center, and the drug is for no more than a 10-day supply and no more than 40 pills. The last exception is if the patient is receiving treatment for cancer, less than or equal to 3-day supply and less than or equal to 26 pills being administered in a healthcare facility. Outpatient surgery, less than or equal to a 10-day supply, and less than or equal to 40 tablets. Treatment for cancer. For Piedmont Clinic members that primarily use Epic, the PDMP can be easily accessed using the review feature, which utilizes a single sign-on so you can access it within the patient's chart. In addition, there are Epic best practice alerts that are set up to remind you if the Georgia PDMP has not been checked in the last 90 days. For those who do not utilize Epic within their clinic or need their support staff to review it, Georgia's PDMP can be accessed through their online portal. Utilizing the PDMP allows providers insight into their patients' opioid use and lets us make more informed decisions to provide safer patient care.
As a practicing provider, I was accustomed to writing narcotic scripts on prescription pads and leaving them at the front desk for the patient to pick up. But in today's world, Epic offers the capability of being able to securely electronically prescribe narcotic medication and have it sent to the patient's pharmacy at the click of a button. Streamlining this process allows you to reduce the number of pills prescribed because you can easily prescribe from Epic if the patient needs more. Additional education links to this information are included in the appendix of this education module. As a provider, a critical aspect of my own patient care is tracking how many opioids I prescribe to my patients. Thanks to the help of Epic's e-prescribing controlled substances dashboard, this is easy to access and makes me aware of my impact in this fight against the opioid epidemic. Utilizing the dashboard allows me to examine my opioid prescribing habits in multiple ways. Also, I have the ability to analyze my inpatient and outpatient prescribing habits. The dashboard can even drill down using your DEA number to show only your controlled substance prescribing habits. All this gives me a better understanding of how I impact my patients and community by ensuring I do not contribute to this growing opioid epidemic. To access the e-prescribing controlled substances dashboard, log into Epic, search ePrescribe, and filter your content type to dashboards. Then select ePrescribed controlled substance monthly data, which will take you to your dashboard. Don't forget to add it to your favorites so you don't have to search for it again. Thank you for letting me share my passion, and I look forward to seeing the results of all your hard work.
The state of Michigan created a program called OPEN to develop a preventive approach to the opioid epidemic by tailoring postoperative and acute care opioid prescribing. They found that among opioid-naive patients undergoing standard surgical procedures, 6 to 10% continue filling opioid prescriptions 3 to 6 months after surgery, and that 72% of opioids prescribed by surgeons go unused by patients. Their research led them to create evidence-based prescribing guidelines based on the specific needs of each procedure. Since they have established these guidelines, opioid prescribing after surgery has declined by 50%. For example, when OPEN looked at patients who reported opioid consumption for thyroidectomy, they examined the number of 5 mg oxycodone pills consumed by 155 patients from 32 hospitals from January 1st, 2018 to May 31st of 2019. They discovered that the 50th percentile of those patients consumed 1 pill and the 75th percentile consumed 4 pills. With that information, they could work with the providers to create a recommendation for prescribing 0 to 5 pills for the guidelines. This is something that I see as the right direction for the clinic, and Piedmont is exploring similar guidelines to standardize prescribing practices and to ensure that we are reducing the chance of opioid misuse.
I'm here to tell you how we use analytics to improve opioid prescribing habits here at the Piedmont Clinic. Similar to Michigan's OPEN program, I was engaged in the start of this effort in February 2022 and based our dashboard on a similar methodology used by Dr. White, a urologist at Piedmont Mountainside. There, he was able to curb opioid prescribing through a process improvement project that he was able to identify using manual chart audits. We have taken that same approach and have used his outstanding work and automated it so that we can have a global view with the click of a button. Upon initial evaluation, the dashboard was quick to identify variations in how opioids are prescribed among many of the procedures completed at Piedmont Clinic. We plan to use this dashboard as our roadmap for improving that together. We have designed the Piedmont Opioid Dashboard to help us better understand our prescribing habits around post-procedural prescribing trends. The logic for this dashboard is simple. You set the date range and the number of days before and after the surgical procedure, and from there it pulls in all of the patients that have had a surgical procedure and prescribed a tablet form of opioid for pain management. From there, we can filter by specialty and procedure to work within all CGCs to help better understand their opioid prescribing habits. We plan to take this information and communicate its findings with all CGCs at Piedmont to ensure that this effort is supported across the organization as we expand our efforts over the years. This will allow the CGCs to work with you to establish a baseline for future projects. Though advanced as this dashboard appears, we think that together with your professional feedback, we can further advance this dashboard and define and refine it for the clinic's needs as we encourage you to engage with your CGC in this organizational effort.
Here at Piedmont, we strive to bring the best care possible. That's why we developed an opioid prescribing project in Atlanta's bariatric program. It's standard practice in general abdominal and colorectal surgery to move towards early recovery after surgery, and we employ alternative therapies to help us reach this goal. To do this, we use the multimodal approach to pain control to reduce the number of narcotics prescribed upon a patient's discharge. For example, all bariatric patients receive a preoperative dose of Tylenol unless contraindicated. To do this, we worked with our anesthesia team to use narcotics sparingly while still controlling the patient's pain. In the first 24 hours post-op, patients are placed on Neurontin or Lyrica, as well as Tylenol unless contraindicated. IV Toradol is also used postoperatively as needed. Patients can receive IV narcotics for severe pain in the first 24 hours. On discharge, they're sent home with a prescription for Neurontin or Lyrica and encouraged to use Tylenol between doses. Patients are also instructed to use other means of pain control, such as ice packs and abdominal binders. We call patients within the first few post-op days, and we advise them based on their current pain level. If needed, a narcotic prescription can be called in at that time. If a patient needs a narcotic prescription, we limit them to 20 pills at a time. Because of this, we've dramatically decreased the amount of narcotics prescribed while still providing adequate pain control. Thank you for letting me share our work, and together we can achieve zero harm.
As a rheumatologist, I see and manage many patients that experience acute and chronic pain. Navigating the treatment plans of patients with pain can be challenging, especially when the patient thinks that chronic opioid therapy is their best option. Chronic opioid therapy is the daily use of prescribed opioids for at least 90 days. In the United States alone, one study estimates that approximately 3% of primary care patients received chronic opioid therapy to help manage their pain. Here at the Piedmont Clinic, we want to mitigate the abuse potential of opioids while still controlling our patients' pain. The first step to pain control is creating an effective treatment plan. This plan should include multiple options and the potential benefits and risks of those options. When drafting their acute pain plan, starting with non-opioid strategies is essential. Opioids can then be added when necessary. This multimodal approach also includes non-pharmacologic methods of pain control, such as physical therapy or immobilization. The acute pain plan should also include a tapering strategy for the opioids. Patients should be involved in the development of their plan and educated on all aspects of the plan. When drafting these treatment plans, it is important to tailor them to the patient's existing or expected post-procedural pain. These plans should be flexible, as pain intensity can be unpredictable, especially in patients who chronically use opioids. It all starts with a conversation. Through these discussions, we can directly impact the patient's success in managing their pain. It is helpful to avoid words like addict or substance abuse. Instead, use opioid use disorder or misuse. These terms will avoid eliciting negative associations, punitive attitudes, and individual blame. Patients are less likely to follow a treatment plan if they are feeling like they are judged. The following scene demonstrates how to effectively discuss an acute pain control plan with the patient.
I'm about to have my second knee surgery in 3 years, and I'm continuing to experience knee pain. And I'm really scared that this second surgery is going to make it worse. And the only thing that's worked for me is those opioid medications.
I'm sorry that you've been in pain, and we will work together to create a pain control plan to help you with this next surgery. I did notice that you were unable to complete your physical therapy after your first surgery.
Honestly, I was good about going at first, but after every time I went, I was in way more pain than I originally was. And what really only seemed to work was the opioid medication that you prescribed me.
Physical therapy will often create pain afterwards, but I have to highlight that it is important for you to regain your mobility and to prevent future pain. And physical therapy is just one tool that we'll use for your pain control. We will create a treatment regimen that will probably include some opioids in the short term, but I have to tell you that long-term use can lead to overdose or opioid misuse disorder.
I wasn't aware of the risks prior to this, and knowing that now, I think I will continue with the physical therapy as recommended.
Well, we will work together to make sure your treatment plan is adjusted so that your pain is controlled.
Certain consistencies have been observed and can serve as red flags for medical providers to alert them that the patient may not have a legitimate pain issue, but are instead seeking narcotics for illegal reasons. It should be noted, however, that any one of these red flags by itself does not necessarily mean that the patient's concern is not legitimate. The Attorney General's office has created a list of instances to help identify patients seeking opioid medications for non-medical purposes, which we have modified based on our patient population. This list includes patients who are not a Georgia resident, requesting a specific drug, states that the alternative drug does not work, states their previous physician closed their practice, states they are not able to provide prior treatment records, comes with a pharmacy profile in hand, comes to their visit carpooling, tests positive for illegal drugs, whose drug test reveals non-prescribed medications in their system, presents with textbook symptoms, pays in cash with no insurance, calls for refills early, whose pain level remains the same, is non-compliant with the treatment plan, prescriptions are routinely lost or stolen. Now that we know these factors, let's see how this would present itself in a clinical setting.
Hello, I see that you have some concerns about your back pain. Can you tell me more about that pain and what you've done to treat it?
Yeah, I was in a horrible car accident 3 months ago, and my back has been killing me ever since. I was going to my doctor and he gave me oxycodone and it really seemed to help, but he went out of business and closed his practice.
Did your previous provider give you any other treatment options such as physical therapy?
Yeah, I tried those things, but nothing worked. The only thing that touched it were the pills.
Has your pain level decreased since you've been on the oxycodone?
No, not at all. It stayed the same. The only time it's better is when I take the medicine. I think I just need a refill.
I understand, and I want to get you help, but I want you to understand that there are other alternatives to treatment and that opioid medications may not be the best option for you.
Are you saying you're not going to be able to help me?
No, I'm saying that I don't think that opioid medications are the solution to your problem and that there are other alternatives to treating your pain.
Life's just been so bad since the accident. I'm in pain all the time. I'm depressed. I have low energy. If you can't help me, I'm going to have to go to someone that can.
I understand, and I'm here to help. I want to be able to help you control your pain, but I'm saying that there may be other alternatives, and of course, if you want to see another provider, that is always an option.
Yeah, I'm going to have to go somewhere where I can get help.
Non-opioid, including non-pharmacologic strategies, are often sufficient for treating mild or moderate acute pain and can prevent the overuse of opioids. If non-opioid strategies are effective but not fully adequate, they should be continued while opioids are initiated. This helps reduce the total opioid requirement for pain control. Non-steroidal anti-inflammatory drugs are widely used to relieve pain and reduce inflammation. They are vital in combating the causes of long-term pain. Some adverse effects can come from NSAID use. They can increase long-term risk of cardiac events, even when used for short duration. They can also cause gastritis, bleeding gastric ulcers, or renal impairment. These should be used cautiously in patients at risk for these disorders. Acetaminophen is another alternative to opioids and is meant to treat minor aches and pains. It is important to review all of your patient's medications, as some oral opioid formulations and many over-the-counter pain and cold medications include acetaminophen. Many patients are unaware of the amount or presence of acetaminophen in these medicines, and this puts them at risk for an acetaminophen overdose. Acetaminophen is contraindicated in patients with severe hepatic insufficiency or progressive liver disease. Another alternative to opioids commonly used in the emergency department is ketamine. This medication is generally well tolerated and has little effect on the respiratory drive. This makes it a helpful treatment for trauma patients. Even in the perioperative world, some studies suggest that ketamine before surgery may reduce long-term opioid use post-procedure in patients who have been designated as chronic opioid users. Regional anesthesia techniques have been found effective in patients with post-operative pain, traumatic injuries, and localized pain. Non-pharmacological treatments are an effective tool in a pain control plan. These treatments include transcutaneous electrical nerve stimulation, acupuncture, massage therapy, yoga, behavioral therapy, or hypnosis. Psychosocial management strategies are effective in reducing chronic pain caused by a traumatic event. Patients who catastrophize their pain are more likely to develop chronic pain. We as clinicians can reduce this by counseling patients about their everyday pain experience, helping them feel safe, ensuring that their concerns are addressed, and avoiding disturbing language or imagery when describing their pain. When talking to a patient with an ankle sprain, you may tell them it's a common injury that typically heals well, or the provider may say that there are micro tears in the muscles and ligaments. Both are factual statements, but the latter is more likely to lead to the patient catastrophizing their pain.
In addition to following opioid prescribing guidelines and exploring alternative therapies, naloxone can help prevent fatalities in the event of an overdose. Naloxone is a life-saving medication that can reverse the effects of an opioid overdose when given in time. It can be given by anyone, even if they have no training for this kind of emergency. According to the CDC, only one naloxone prescription is written for every 70 high-dose opioid prescriptions. The CDC recommends offering naloxone to patients receiving high opioid dosages greater than or equal to 50 morphine milliequivalents per day, or having other risk factors for overdosing, including the use of benzodiazepines. Unfortunately, the use of naloxone has been stigmatized at times, so it's necessary to educate patients that a person does not need to be dependent on opioids or intentionally misuse opioids to overdose. Even if a patient believes an opioid overdose would never happen to them, emphasize the benefits of having naloxone on hand, especially if they have risk factors that increase their risk for overdose. To reduce stigma, avoid words like addict and abuse, and instead use more non-judgmental terms like person with a substance use disorder or misuse. Patients, family members, and caregivers should be taught the signs of an opioid overdose, such as shallow breathing. When they see these signs, they should be educated to call 911, give naloxone, and support the patient's breathing until emergency services arrive.
Because you take chronic opioid medication, I wanted to talk to you about a safety drug that we can give you. It's a medicine called naloxone, and it is used for temporary restoration of your breathing.
I'm not an addict at all, but I've been taking these medications for so long. What is this?
Yes, and we're not saying that you're an addict, but it is a thing that could happen where you could have an accidental overdose or you could have depressed breathing, and that could cause you some problems. So this is more for your safety.
Interesting. So when would I or my family member use this?
Well, if you had, problems waking up, or you had gurgling sounds or choking sensation or an accidental overdose, this would be something that your family could use by shot or through your nose to temporarily restore your breathing until the paramedics came.
As you can see, this may not be an easy conversation, but it is necessary with all of your patients who are at risk of an opioid overdose, because naloxone can save lives when given at the right time.
Proper disposal of unused opioids is important in combating opioid misuse. Several disposable methods exist. Self-disposal of unused opioid medication within the patient's home might be their most convenient option. However, we want to ensure they are doing it correctly and not harming our environment. According to the Food and Drug Administration, we should not flush any drugs down the toilet or drain unless instructed explicitly on the label or drug guide. You can also find this information on the FDA's flush list, which indicates what opioid medications are okay to flush. Throwing away medication in the trash is another option. The drug should be taken out of the original container, mixed with an undesirable substance to ensure that it is no longer suitable for human consumption, and placed in a disposable container. Patients can also mail the unused opioids back to the pharmacy for disposal. You will need to inform your patient that they will need to verify that their pharmacy provides a mail-back option before they attempt to mail anything back to their pharmacy. With pharmacies that do provide mail-back programs, you will need to inform your patient that it will require them to purchase an envelope approved by the Environmental Protection Agency, Drug Enforcement Agency, and the U.S. Postal Service. These can be found at your local post office or office supply store. The best option is to have the patient drop off unused opioid medication at a medication drop box. For those of you who may not be aware, this option is the most effective, efficient, secure, and environmentally friendly way for a patient to dispose of unused opioid medication. In the state of Georgia, there are drug drop boxes in sheriff and police departments across the state in 153 counties. To direct a patient to one of these medication drop-off locations, there is a list of 180 places available on the Georgia Prescription Drug Abuse Prevention Initiative website.
There are many tools at our disposal for us to address the opioid epidemic. We believe that together we can make a positive difference in every life we touch by utilizing these tools. Thank you so much for joining us in our efforts to reach our goal of zero harm for our patients.